Imagine you're in an emergency department. Maybe it's late, you're not feeling great, or you're there with someone you care about, and you're waiting. Waiting to register, waiting for triage, waiting to see a doctor, waiting for tests. It could be really frustrating, right? Sometimes chaotic.
Definitely.
And while you're sitting there, maybe you start thinking, surely there's got to be a better way. Couldn't this whole process be smoother? Maybe, more humane?
It's a common thought, I think.
Well, today, that's exactly what we're diving deep into. We're exploring how one large public hospital in a major city totally transformed its emergency department.
And this wasn't just any ED.
No, exactly. This was a safety net hospital serving really vulnerable patients under just immense pressure. And the way they did it, using something called Lean Methodologies, which, kind of surprisingly, comes from the world of manufacturing.
That's right. So our mission here is to systematically unpack how these lean principles, methods you might associate more with a car factory, were applied in this incredibly high-stakes healthcare setting.
We'll look at the real-world impact, what these changes meant for patients and efficiency. And crucially, we'll pull out the key lessons learned, especially from the challenge of doing this in a resource-strapped safety net hospital.
And we're basing this on some solid research.
Yeah, primarily drawing from the paper, A Structured Approach to Transforming a Large Public Hospital Emergency Department via Lean Methodologies by Trushar Naik and a whole team of colleagues.
Okay, let's unpack the why first. Why was this kind of massive change even necessary? Emergency departments today, they're under almost unimaginable pressure.
They really are.
You've got more and more patients coming in, often sicker patients, higher acuity, right?
Right, the complexity is increasing.
Plus an aging population, and all this while money's getting tighter, declining reimbursements. It's a tough situation.
It's a real squeeze.
Yeah.
You're constantly expected to deliver high-quality, safe, efficient care, but the resources often aren't keeping pace.
A real tightrope walk. And this relentless pressure, well, that's exactly why many health systems started looking outside of traditional healthcare for answers. They faced these huge operational hurdles and began exploring strategies from, business and manufacturing.
So thinking like a factory almost.
Sort of, yeah. Viewing ED operations through an input-throughput-output lens. The idea was, look, if you can streamline how things flow on an assembly line, maybe you can apply similar thinking to how patients and care flow through an emergency department.
Which brings us neatly to lean methodology. Now, this isn't just a buzzword, is it? It sounds like a whole philosophy.
It absolutely is. It's much more than just tools. It's a comprehensive way of thinking, a structured system for solving problems. At its core, Lean really aims to bring everyone, leaders and frontline staff, together.
Focused on what exactly?
Focused on continuously improving productivity, efficiency, and quality, all with the goal of delivering the maximum possible value to the customer. And in healthcare, that customer is always the patient.
And a big part of that is getting rid of waste.
Exactly. The central principle is eliminating muda, the Japanese term for waste. Basically anything that doesn't add value from the patient's perspective.
What does that look like in an ED? It's not like leftover parts on a factory floor.
No, but the waste is definitely there. Obvious things like patients waiting, sure, but also excessive processing, filling out the same info multiple times, unnecessary motion staff walking back and forth for supplies, defects like errors in orders, even just misallocating staff or resources.
Things you might not even notice because it's just how things are done.
Precisely. It becomes invisible. But Lean also brings in other key ideas you might have heard of. Kaizen, which is all about continuous small improvements. Haijunka, trying to level out the workflow, avoid those peaks and valleys. Poka-yoke, which means error-proofing processes, building checks and so mistakes are less likely. And Jidoka, empowering staff to actually stop the process if they see a problem, to fix it right then and there.
Okay, so it's a whole system. But you mentioned tools earlier. What makes it practical?
Right, the philosophy needs tools to make it happen. What's fascinating here is how they applied these. One key tool is value stream analysis, or VSA.
Okay.
This isn't just drawing a flowchart. It's a really deep analysis of every single activity involved in delivering care from the moment the patient arrives to the moment they leave. You meticulously map it all out.
To find the bottlenecks.
Exactly. To identify which steps actually add value for the patient and which ones are just waiting, moving, redundant checks, you name it, it makes the invisible friction visible.
And then you have these rapid improvement events, RIEs. They sound pretty intense.
They are. RIEs are these focused team-based workshops, often a full week long. You get a diverse team, nurses, doctors, techs, registration staff, sometimes even patients focused on one specific process.
For a whole week?
Yeah, they analyze it, brainstorm solutions, and this is key, they immediately test new workflows right there. The idea is rapid change, not months of planning. Quick improvements, tested on the spot.
Wow, okay. And standard work, what's that about?
Standard work is about defining the current best-known way to do a specific task. It sounds rigid, but it's not about stopping improvement. It's about creating a stable, predictable baseline.
So everyone does it the same, best way for now.
Right. It reduces variation, ensures consistency, ensures quality. Then you can improve upon that standard. It's the foundation for Kaizen.
Makes sense. And one more A3 thinking.
Yes, A3 thinking. This is a structured problem-solving method where literally the entire process, defining the problem, analyzing it, proposing solutions, creating an action plan, follow-up, it's all captured on a single sheet of A3-sized paper.
Like a one-page summary for change.
Exactly. It forces clarity, conciseness, and shared understanding. Really powerful for communication.
Okay, powerful tools indeed. So let's connect this back to the case study.
Yeah.
This ED in New York City. You said it was a safety net hospital, a trauma center, a teaching hospital. That sounds complex.
Incredibly complex. Being a safety net means serving a large number of patients who are uninsured or on Medicare and Medicaid, about 44% self-pay, 40% Medicare Medicaid in this case.
Which impacts resources, right?
Hugely. It limits revenue, making big investments in staff or equipment really difficult. Plus, add in the high volume, over 130,000 patients a year, and a largely unionized workforce, which can sometimes make changing roles or processes, well, more complicated.
So transforming this place was a major undertaking. How did they even start?
It really began at the top, with executive vision and hospital-wide alignment. There was a hospital executive lean steering committee. They identified these big-picture goals, what they called true north metrics.
Things like quality, cost.
Yeah, things like human development, quality and safety, access and timeliness, cost, and even growth revenue. And they used a scoring tool to rank all the hospital's value streams.
And the ED came out as a priority.
It did. It was identified as a key area where improvements could have a massive impact. The whole hospital had a goal to improve timeliness of care by 20%, and the ED was central to that.
That's smart, linking the department's work to the hospital's overall strategy.
Absolutely essential. Then came departmental planning. They formed an ED-specific Lean Steering Committee leadership, key staff, all trained in Lean. They did their own deep dive VSA for the EB.
Mapping the current mess.
Well, mapping the current state, yes. Then defining a vision for a better future state, and clearly identifying the gaps they needed to close.
And they used those RIEs you mentioned?
They did, but very strategically. They used structured RI sequencing over 18 months. They didn't just randomly pick processes.
How did they sequence them?
Cleverly. They sequenced the RIEs to follow the patient's journey through the ED, from entry to triage to the main treatment area to disposition. The idea was that improvements would build on each other. Fix the front door first, then the next step.
Like building blocks? Makes sense. How did they track progress? Did they know if it was working?
Yes, through clear performance metrics and sustainment goals. They set specific ED targets, like that 20% reduction in time from entry to seeing a provider. They tracked these metrics monthly.
And sustainment, what did that mean?
A process change was considered sustained if it met its target for 3 months straight. If not, the committee would step back in, analyze, tweak the process. Constant monitoring and adjustment.
Okay, this is where it gets really interesting. Let's talk about the actual changes. Paint a picture for us. Before Lean, what was that initial registration and triage like for a patient?
Oh, it was often that classic ED shuffle. You'd register at one spot, then go sit down, get called for triage, maybe basic vitals, then back to the waiting room, wait again, maybe get called back for something else. Lots of movement, lots of waiting.
Frustrating. So how did Lean change that?
They completely redesigned registration and triage, moved to a streamlined, single-location team approach. Basically, you'd arrive, get registered, triaged, and often have initial orders placed, all in one area, much faster. Less back and forth, much less waiting room time initially.
Huge difference right at the start. What else? Radiology often seems like a bottleneck.
It often is. Before, it was a push system. The ED would send the patient to radiology, where they might wait again. Radiology didn't always know who was coming or how urgent it was.
So the change?
They flipped it to a pull system, Radiology staff became proactive. They'd actively come get patients from the ED when they were ready for them. It required coordination, but it dramatically cut waiting times and ED staff time spent chasing results or coordinating trips.
That's clever. What about just managing the flow of patients within the ED?
Yeah.
Keeping track of everyone.
Big changes there, too, around the charge nurse and patient flow. They ditched a clunky paper tracking system and fully embraced an existing computer system they hadn't been using effectively.
Okay.
And critically, they shifted responsibilities. Nurses took over things like calling patients back, checking beds, tracking availability tasks maybe doctors were doing before, freeing up physician time. They even created a dedicated patient flow coordinator role.
Someone whose whole job is just keeping things moving.
Exactly. Smoothing out the bumps, anticipating bottlenecks, coordinating movement. And another big one was putting a mid-level provider in triage.
Like a physician assistant or nurse practitioner. What did that achieve?
Yes. This allowed them to use protocol-based order sets right after triage for common, less severe complaints. Get basic tests ordered immediately.
So quicker workup for some patients.
Much quicker. It meant faster treatment and discharge for those treat and release patients, which then freed up beds and staff in the main ED for sicker patients. A real win-win.
And they tackled other things, too. Smaller stuff.
Oh, yeah. RIEs looked at everything. Consolidating supplies so staff weren't hunting everywhere. Standardizing what goes in each treatment room. Creating better queues for blood draws. Redesigning how admission bed requests were handled. Every bit of identified waste was a target.
Okay, so it sounds like a massive overhaul. Did it actually move the needle? What did the numbers show? Especially, as you said, with more patients coming through the door during this period. That 7.3% increase is significant.
It really is. And yes, the data was pretty compelling. Despite that increased volume, key metrics improved significantly. Take the median login to disposition time, total time in the ED.
Right.
That declined from 4.6 hours down to 4.0 hours, a reduction of 0.6 hours, or 36 minutes.
36 minutes faster on average for the whole visit.
Yeah.
While being busier. That's huge.
It's a massive improvement for patient experience and for overall flow. And other metrics improved too. Median login to triage time, how long you waited just to get assessed initially. That dropped from 0.6 hours to 0.3 hours, cut in half.
Wow.
And the median login to provider time, the wait to actually see a doctor or provider, went from 2.1 hours down to 1.6 hours, over half an hour faster.
So less waiting at each key stage. What about the staff? Did this just make them work harder, faster?
Interestingly, no. Provider productivity actually improved by nearly 19%, 18.8% in the quarter after the full Lean rollout. It suggests they were working more effectively, not just harder.
Fewer roadblocks, maybe?
That seems to be the implication. Now, we have to be fair. This is an observational study, not a controlled trial. So you can't say Lean caused this with 100% certainty. There could be other factors, maybe a Hawthorne effect, people working differently because they know they're being studied.
Sure, the usual caveats.
Right. But the timing is striking. There was a clear inflection point where improvements took off right after Lean started. And anecdotally, the providers themselves reported things felt much smoother, less chaotic.
Okay, the results look impressive. But how did they make it work? Beyond the tools and methods, what were the crucial success factors? What are the big lessons here for anyone thinking about this kind of change?
I think one of the absolute biggest takeaways was the critical role of executive commitment. This wasn't just passive support. Hospital leaders, both top executives and ED leadership, had to be visibly involved.
What did that look like in practice?
It meant showing up to RAE report outs, actively helping to remove barriers, maybe an old policy needed changing, or a job description tweaked. It meant allocating small amounts of resources when needed. That visible backing sent a powerful message and cleared roadblocks.
So leadership couldn't just delegate this?
No, they had to champion it. But it wasn't just internal commitment. Another huge lesson was external stakeholder engagement.
Meaning other departments.
Exactly. Think about it. The ED doesn't function in a silo.
Yep.
Radiology, labs, admitting, consultants, they're all crucial partners.
Right.
The study found RAEs were much more successful when leaders from those outside departments were actively involved, like radiology converting to that pull system that happened because their leadership was at the table, helping design and implement it.
And when they weren't involved?
Things struggled. An RAE trying to improve consultant workflow, for example, had trouble meeting its goals because not all the consulting services fully engaged. It really highlighted that you need buy-in across the whole patient pathway.
Makes total sense. But Okay, you make these great changes, everyone's excited.
Yeah.
How do you make them stick? That seems like the hardest part. Sustainment.
Oh, sustainment is always the challenge. It's human nature to drift back to old habits, especially under pressure.
What caused things to slip back?
Common culprits were maybe insufficient training on the new way, especially for newer staff or those on different shifts. Sometimes unique conditions, like on the night shift, weren't fully accounted for in the redesign. Or just sheer volume. A massive surge of patients could overwhelm a new process, causing staff to revert to what felt familiar, even if it was less efficient.
So how did they fight that gravity, pulling things back to the old way?
Several key strategies. First, really clear communication and thorough in-servicing practical on-the-job training was essential. Everyone needed to understand the why and the how.
Okay.
Second, they tried to launch new processes during off-peak times. Have the process owners, maybe even executives, physically present to support staff, answer questions, and troubleshoot in real time.
Hand-holding almost, initially.
A bit, yeah. Build confidence. Third, and this is vital, they made sure to include representatives from all shifts in the RA. Night shift, weekend shift. Their perspectives were crucial for designing robust processes.
So the solutions work 24/7.
That was the goal. And finally, perhaps most importantly, they cultivated clinical champions. These were frontline staff, nurses, doctors, techs who were part of the RIs, really understood the new workflows and became advocates and resources for their peers.
Peer-to-peer support.
Invaluable. Having a colleague explain and champion the change is often more effective than a memo from management. These champions were key to embedding the changes in the daily culture.
Let's circle back then to the specific context here. A safety net public hospital. You touched on the resource constraints.
Yeah.
What other unique hurdles did this kind of hospital face in pulling off such a transformation?
Well, those resource limitations were huge, as we said. Limited ability to just throw money or staff at problems meant they had to innovate with what they had. Efficiency wasn't just nice, it was essential.
They had no other choice, really.
Pretty much. Then there were workforce challenges. With a heavily unionized environment, simply changing job descriptions or implementing performance incentives isn't straightforward. It requires careful negotiation and collaboration, respecting existing agreements.
Adds another layer of complexity.
Definitely. And finally, just the inherent challenge of culture change anywhere, but maybe amplified in a place with many long-tenured staff who've seen initiatives come and go. Overcoming skepticism and inertia takes real persistence.
So despite all that,
Despite all those unique hurdles, they showed it could be done. And the lessons learned about managing change, engaging staff, and applying these systematic methods, they have really broad applicability, even outside of a safety net setting. It's a powerful case study in organizational transformation under tough circumstances.
it really has been a fascinating deep dive. The
Yeah.
big message seems to be that lean, when it's applied thoughtfully, systematically, with real commitment from everyone, it truly can transform even the most complex, high-pressure places like a busy ED. And the results aren't just numbers on a page. They mean a better, faster, safer experience for patients, and actually a potentially less chaotic, more effective environment for staff, too, even when facing huge challenges.
Absolutely. So what does this all mean for your world, listening to this? This idea of continuous improvement, Kaizen, it isn't just for giant hospitals or factories. It really makes you wonder, doesn't it? What processes in your own life, maybe in your team at work, or even just how you manage your day, what could benefit from a sort of mini value stream analysis? Where's the waste, the waiting, the unnecessary steps, the friction?
Applying it personally.
Yeah. And maybe more importantly, who could be your champions? Who could help you drive and sustain those improvements, whether it's a big project or just a small tweak to make things run a bit smoother? The lessons here about identifying waste and empowering people to fix it, they really can apply almost anywhere.